Welcome, everyone. My name is Dr. Ajay Singh. I'm a member of the Renal Division at Brigham and Women's Hospital and Senior Associate Dean for Postgraduate Medical Education at Harvard Medical School. I'm also the Director of the Intensive Review of Internal Medicine course. This is a renal board review for the IRIM course 2020. This is my disclosure slide. So question one, this is a 65-year-old white male with a history of hypertension and diabetic nephropathy who sees you via a virtual visit on Zoom. He's very concerned about the news that patients on ACE inhibitors are at higher risk of COVID-19. His hypertension treatment includes lisinopril, amlodipine, and hydrochlorothiazide. His blood pressure self-measured at home is 148/62, creatinine 1.8, and he has about half a gram of protein in his urine. The options you have. You should advise him that A, you will switch him to another non-RAAS inhibitor, non-renin-angiotensin system inhibitor. B, you reassure him that there is no evidence for discontinuing ACE or ARB. C, you switch him from ACE inhibitor to ARB. And D, you tell him that in fact ACE or ARB treatment is actually protective. So I'm going to pause for a second and let you digest this information and make your choice. So the correct answer is you reassure him that there is no evidence for discontinuing ACE inhibitor or ARB. And obviously this is an area of great controversy, or had been during the COVID-19 pandemic. Should we be worried about patients who are already being treated with ACE and ARB? Should we take them off this agent? For those patients presenting with diabetic kidney disease or hypertension, should we start them on ACE and ARB? So this was a very, very big issue. This next slide shows schematically what we're talking about. So on the left-hand side, you see the COVID-19 virus, SARS-CoV-2, and the typical spike proteins, and this virus then binds via spike protein to ACE2 and then enters into the cell, goes to vesicles and ends up getting replicated. On the right-hand side, you see that ACE inhibitors and ARBs are important in preventing the binding of angiotensin 1 to angiotensin, or conversion of angiotensin 1 to angiotensin 2, that's ACE inhibitors, or the binding of angiotensin 2 to the angiotensin 2 type 1 receptor, that's ARBs. Because of the effects of these two agents, you get, in fact, these compounds formed, angiotensin 1,9 or angiotensin 1,7, that bind ACE2. And it's hypothesized that ACE inhibitors and ARBs result in increased expression of ACE2, and that by virtue of increased expression of ACE2, you get an increased binding of the SARS virus, and so increases the risk of COVID-19. The counterpoint to that is that, in fact, these agents could be actually beneficial, because use of ACE and ARBs might actually prevent the angiotensin-mediated injury to the lung and adverse myocardial modeling, vasoconstriction, and vascular permeability that occurs with active COVID-19 infection. So you have a yin and a yang here. ACE and ARBs might actually, at least hypothetically, increase ACE2 expression and increase binding to the SARS spike protein, and therefore increase risk of COVID-19, at least hypothetically, or in counterpoint, they may actually be protective because they may reduce the cytokine surge and the acute lung injury that you might see in patients with COVID-19. And this is expressed on this panel on the right-hand side. A number of papers have been published, and I'm going to briefly review them with you. The first paper is a paper that was published in JAMA in April of this year, and this looked at 5,700 patients hospitalized with COVID-19 in the New York City area, and they covered 12 hospitals in New York City, Long Island, Westchester County. And the bottom line was that in this paper, at least, they reported in an unadjusted analysis that there was an increased risk of mortality in patients who were being treated with an ACE and ARB compared to those not being treated. And you see this difference here. 26.6% of those patients not on ACE or ARB, and 32% on ACE and 30% on ARB. But the key word I used there was it was an unadjusted analysis. It didn't adjust for comorbid features these patients might have, and that's critical. When you went to the supplementary section of this paper, you did see that in subgroups such as patients who have hypertension on ACE or hypertensives on ARBs, their complication rates were higher. There were a higher rate of invasive mechanical ventilation or ICU cares compared to those patients who were hypertensive who were not being treated with ACE or ARB. But the interesting point here is that this was an unadjusted analysis. And so that's the key feature. When another paper published in JAMA Cardiology looked at the same issue, this was a retrospective single center study from Wuhan in China over roughly the same period, just a little bit before January to March 2020. And they again did this analysis. What they found that there was no increase, there wasn't an increased risk of adverse outcomes among patients treated with ACE or ARBs. In patients with just hypertension not on these agents, it was 30%. Patients with hypertension treated with ACE or ARBs, it was 32%. So this was the counterpoint. Interestingly, in another paper, this is a paper published in Circulation Research, also from Wuhan. They looked at this relationship, and in fact, they found another interesting association that they reported a lower risk of COVID-19 mortality on patients treated with ACE or ARB versus those who were not on ACE or ARBs. And this was statistically significant even when they adjusted for comorbid factors. So what's the truth in this? And so we were sort of left quite unsure of what the situation is. Some people say it's protective, some people say it's harmful, some say it has no effect at all of being on treatment. I think the final word on this came May 1st, 2020, in 3 papers published in the New England Journal of Medicine, depicted on your screen here. And basically the common message from these 3 papers was that prior treatment with ACE or ARBs did not increase the risk of adverse outcomes in patients with COVID-19. And indeed, in an editorial published by the deputy editors of the New England Journal of Medicine, May 1st, 2020, they came up with the following point. They basically said that professional scientific societies and experts have spoken with one voice in advising that patients should not discontinue ACE inhibitor or ARB therapy out of a concern that they are at increased risk of infection, severe illness, or death during the COVID-19 pandemic. And so in that sense, they are backing up the recommendation from the American College of Cardiology and the American Heart Association, quoting, no experimental or clinical data demonstrating beneficial or adverse outcomes with background use of ACE inhibitors or ARBs, unquote. Question 2. A 22-year-old woman is admitted with a diagnosis of Goodpasture syndrome. This diagnosis is confirmed by an ELISA and a Western blot, which both suggest that Western blot demonstrates anti-GBM antibodies. A preliminary reading of the renal biopsy confirms the diagnosis of anti-GBM nephritis. Her serum creatinine is 3.2 milligrams per deciliter. 2 weeks previously, her serum creatinine was 0.7 milligrams per deciliter. So this patient has a rapidly progressive disease. And in this patient with a confirmatory diagnosis based on laboratory assays, she has anti-GBM nephritis. And you see, creatinine has more than doubled from 0.7 to 3.2. And so this is one of the few medical emergencies in nephrology. And so the question for you is, which of the following therapeutic options would be most appropriate for her? This is shown on the next slide. A, prednisone 60 milligrams per day for 1 month, followed by a gradual weaning of a prednisone dose. B, pulse methylprednisone accompanied by daily plasmapheresis with exchange, followed by high dose oral prednisone coupled with cyclophosphamide until her anti-GBM titer is undetectable. C, pulse methylprednisone followed by high dose oral prednisone coupled with cyclophosphamide until her anti-GBM titer is undetectable. D, prednisone 60 milligrams per day plus cyclophosphamide 3 milligrams per kilogram per day, or E, plasmapheresis alone. I'll give you a second to make your choice. So the correct answer is B. And obviously, you always suspect that when you get such a big blurb as part of the option. But the correct answer is all of the therapies, right? Pulse methylprednisone, followed by plasmapheresis with exchange, followed by high-dose oral prednisone coupled with cyclophosphamide until an anti-GBM titer is undetectable. This is the treatment that's been there for decades. So some background to this. This is a picture of Ernest Goodpasture. He actually joined the Brigham and Women's Hospital and Harvard Medical School in 1912 as a pathologist. And then subsequently, while in 1919, Goodpasture was studying the influenza pandemic. This is the Spanish flu, if you will. He described a progressive and usually fatal disease in which glomerulonephritis was associated with coughing of blood. Most of the patients died of kidney injury, and since this time, this syndrome has been named Goodpasture syndrome, the pulmonary hemorrhage in association with anti-GBM nephritis. Indeed, in 1924, he was invited to return to Vanderbilt as professor and chairman of the Department of Pathology in the reorganized Vanderbilt University School of Medicine, and he served there for many years with great distinction. So some learnings about Goodpasture syndrome. It's an uncommon syndrome. It's common in the boards, but quite uncommon. In the past 10 years, in my nephrology practice, I've seen it maybe 3 or 4 times. Incidence is about 0.1 case per million. And it's diagnosed in about 1 to 2% of all renal biopsy specimens. There's a slight preponderance in males, but it can occur in anyone from the first decade to the 9th decade. It's more common in whites over African Americans. It has a year-round presentation, but some people believe it's more common in spring and summer. And about 50 to 75% of patients, there is a concurrent upper respiratory prodrome or infection with fever, rash, myalgias, malaise, headaches, weight loss. On this next slide, you see the pathological features, and see on the left is H&E staining of the kidney at high power. You see the glomerulus. You do not see Bowman's capsule, and see Bowman's capsule filled with a cellular infiltrate, which is in fact a cellular crescent, a circumferential cellular crescent in Bowman's capsule. So, and this is because inflammatory cells leak out of breaks in the capillary membrane of the glomerulus and then cause an inflammatory reaction in Bowman's capsule, causing this circumferential crescent. This causes then a collapse of the glomerular capillaries, and you see them here. And you also see that they're engorged and there's an inflammatory infiltrate. When you look on the right-hand side on immunofluorescence, you see linear staining, and you see that linear staining because of continuous expression of the antigen to which this antibody is reacting, and you see that it's staining here very bright of IgG. Goodpasture syndrome generally presents with rapidly progressive glomerulonephritis. It's a very typical case was presented to you. You can see proteinuria, but patients are usually not nephrotic because there is insufficient time. Hypertension is also not common because there's insufficient time. The kidneys are also normal in size because there isn't any time. This is a rapidly progressive disease, and renal function declines very quickly, so that if you don't do anything, these patients are often on dialysis within several weeks. Goodpasture syndrome, the treatment shown on this slide. Treatment, if you just use, if treatment occurs without methylprednisone and plasmapheresis, about 90% progress to death or dialysis, only 10% improve. So that's certainly not what you want to be doing. The recommended treatment is treatment with pulse steroids, high dose, methylprednisone, usually a gram of methylprednisone on 3 consecutive days, followed by oral prednisone, plasmapheresis, which is plasma exchange. So you replace the patient with plasma, and cyclophosphamide. This is the standard of care, and about 50% of patients improve. Now, in patients with a serum creatinine greater than 7, the response of treatment is really poor. And so in studies, rapid treatment is really important, because if you allow the patient to progress up to creatinine of 7 or greater, the damage is too great, likelihood of scarring too much, and so these patients often never recover. So 75% of patients with creatinines of less than 7 respond, whereas only 8% of patients with creatinines of greater than 7 respond. And certainly there's virtually no likelihood of improvement of patients who are dialyzed. And the protocol is shown here. So pulse methylprednisone, cyclophosphamide plasma exchange with 4 liters of daily 4 liters with albumin replacement or FFP, fresh frozen plasma, if pulmonary hemorrhage is present. So in patients with good pastures, you're going to be replacing with fresh frozen plasma. Whereas in patients with GBM nephritis, you might be just using albumin replacement. And you do that for 14 days or until the antibody disappears. Question 3. In all of the following conditions, an increase in serum creatinine can be explained by a reduction in GFR, except A, bilateral hydronephrosis, B, severe extracellular volume contraction caused by diarrhea, C, severe congestive heart failure, D, increase in serum creatinine 1 day post-arteriogram, and E, cimetidine treatment of peptic ulcer disease. So I'll wait for a second for you to make your choice, and then we'll get to the right answer. So the correct answer is E, cimetidine treatment of peptic ulcer disease. So what's the background to this? So serum creatinine is a marker for kidney function. As you know, creatine is formed through the daily metabolism of muscle, which we all have, and this creatine is converted to creatinine. So every day there's a little bit of creatinine that's released, and then that gets freely filtered by the glomerulus, and a small portion or fraction of it gets secreted, and some of it undergoes extrarenal degradation. So that's how creatinine is metabolized. This serum, this creatinine levels change based on kidney function. So as kidney function goes down, the filtration goes down, so the clearance of creatinine goes down, so creatinine levels goes up, and the proportion of creatinine that's secreted actually increases, and the proportion of creatinine that undergoes extrarenal elimination through the GI tract increases. So in patients with kidney disease, secretion of creatinine forms a greater proportion of the total amount of creatinine that's excreted than in people with normal kidney function. Now, there are two facts. One is that means that any medications that influence secretion of creatinine by the proximal tubule will ultimately influence the creatinine level. So if you have a medication such as cimetidine, it will block creatinine being secreted by the proximal tubule, and so serum creatinine levels will go up. If you have someone who has very high muscle mass, serum creatinine levels are higher, because on average more of that muscle mass ultimately gets gets degraded on a daily basis through wear and tear, and more creatine is secreted, and therefore more creatinine is secreted. So very large, bulky patients tend to have higher baseline serum creatinine levels. The other thing is, if you eat very high containing meat meals, you will increase your creatinine level, but transiently. So if you have 2 steaks the night before you have the creatinine measured the next day, your creatinine level will be a midge higher than normal. The sensitivity of creatinine as a GFR measure is approximately 60%. So it's not great, but it is the best that we have right now. So creatinine production is proportional to muscle mass, and you can see here males have slightly higher muscle mass than females, so have higher creatinine excretion. It's secreted by an organic cation exchanger in the proximal tubule of the nephron, and drugs that interfere with proximal secretion include cimetidine, trimethoprim, dapsone, and probenecid. And these 4 drugs are important to remember, and this will come up in the boards. This table just summarizes the effect on creatinine, serum creatinine based on various conditions, and just is a nice summary for you to look over. Question 4. The most common type of kidney stone observed in the United States is A, cystine stone, B, triple phosphate stone, C, struvite stone, D, calcium oxalate stone, and E, uric acid stone. So I'll wait for a second for you to make your choice, and then we'll look at the right answer. Okay, the correct answer is calcium oxalate stone. That's by far the most common cause of a kidney stone in the United States. So just some facts about nephrolithiasis. About 12% of the US population is affected. The incidence rate among individuals who are aged between 30 to 65, 3 times more common in males than females. Calcium oxalate accounts for greater than 75% of all kidney stones, and risk factors include hypercalciuria, hyperoxaluria, hypocitrikuria, so lower citric acid in the urine, and hyperuricosuria, so more uric acid in the urine. The other stones are infection stone or magnesium ammonium phosphate stones. So these struvite triple phosphate stones form 7 to 15% of all stones. Uric acid stones about 2%, calcium phosphate stones about 2%, and cystine stones less than 1%. This is the different types of kidney stones. So you see the envelope stones, which are the common calcium oxalate stones. These are envelope stones. The coffin-shaped stones, which are triple phosphate stones, and the hexagonal stones, which are the cystine stones. These are very rare stones or crystals to see. You'll see them in the boards, and you see hexagonally shaped crystals with this gunky material in the middle. Question 5. A 60-year-old man who has been previously in good health and on no medication develops the nephrotic syndrome. No systemic causes are identified, and serological workup is completely negative. The most likely histological lesion seen on his percutaneous renal biopsy is A, light chain nephropathy, B, membranous glomerulopathy, C, myeloma kidney, D, membranoproliferative glomerulonephritis, and E, IgA nephropathy. I'll pause for a second while you make your choice. So the correct answer is membranous glomerulopathy. So let's think about some points about membranous glomerulopathy. So the most common causes of, or the most common cause of membranous is idiopathic. It's usually insidious in onset, so that it goes gradually. Males, more common than females by a proportion 2 to 3 to 1. About 80% of patients with membranous nephropathy present with nephrotic syndrome at presentation. And about 20% are asymptomatic and non-nephrotic in their level of proteinuria. So they have only modest amount of proteinuria. About 50% of patients with nephrotic syndrome, in fact, have hematuria. Hypertension is not common. It only occurs in about 1/3 of patients. And patients with nephrotic syndrome from membranous are an increased risk of thromboembolism, about 15 to 40% risk, particularly those patients with albumins of less than 1.5 gram per deciliter. And so, you need to think about in these patients anticoagulation with either using aspirin at the very least, or perhaps even using heparin as treatment. And usually in membranous, there is an insidious decline in GFR. So this shows you 75% of patients have idiopathic membranous, and about 25% have secondary causes, of which the leading etiologies are lupus, hepatitis B, non-steroidals, malignancy, toxins such as mercury, and other causes. Now, the one important new thing that's come out with membranous is that we've discovered the etiology of membranous is related to this M-type phospholipase A2 receptor. So this is a 185 kilodalton type 1 transmembrane glycoprotein that's expressed in the kidney, lung, placenta, and white cells. And the details are not important, but it's a member of the mannose receptor family. And it binds certain serum PLA2, the receptor. And it may play a role in cellular replicative senescence. And what's important is that an antibody to this receptor is associated with membranous nephropathy. So in patients who have elevated levels of this receptor or elevated levels of this antibody, you see tend to be nephrotic. When you treat them, the level goes down and they go in remission. When they relapse, you see an association of an increased level of this antibody. And see here the almost linear association between the presence of this antibody and proteinuria. Question 6. This is a 16-year-old woman who presents with a history of a sore throat 2 weeks previously. She has also edema, mild hypertension, hematuria, and red cell counts on her urine sediment. Her complements are low. The most likely diagnosis is A, minimal change disease, B, post-infectious glomerulonephritis, C, IgA nephropathy, D, acute interstitial nephritis, or E, light chain deposition disease. I'll wait for a second and then we'll move on. So the correct answer is post-infectious glomerulonephritis. And really the main reason for this is that this patient has this prior 2-week history of a sore throat, and then she has what looks like a glomerulonephritis, and her complement levels are low, suggesting that the etiology is post-infectious GN. None of these other causes are associated with, usually associated with a low complement level. So post-infectious GN, this is a long list of potential causes. The most important one, and for the purpose of the boards, most important one you need to know is group A beta streptococcus. Most common cause of post-infectious GN, this is post-strep GN. But there are, importantly, be aware that there are other bacterial, viral, and parasitic, and rickettsial and fungal causes for GN from infectious agents. But this one particular etiology stands out. Some key points about post-streptococcal GN. It usually follows a pharyngeal or skin infection. Only specific nephritogenic strains, M-type, serotype 49, cause this. Now, I just will point out that in patients with IgA nephropathy who have hematuria and glomerular nephritis, the pharyngitis is synpharyngitic, meaning it occurs roughly at the same time as disease presentation. Whereas in post-streptococcal GN, it occurs usually 2 weeks before. In other words, there's a latent period. And in patients with pharyngeal disease, about 1 to 2 weeks, whereas patients with pyoderma, it's 2 to 3 weeks. This post-streptococcal GN, for unclear reasons, is primarily a disease of children. It's rare in very young, and it's rare in those over the age of 40. Presentation of glomerulonephritis, hematuria in 70% of patients, periorbital edema, weight gain, hypertension, oliguria. The urine analysis usually shows proteinuria with less than 2 grams per 24 hours. There's red cells, red cell casts, white cells, and white cell casts. Usually the fraction excretion sodium is less than 0.5% in the acute phase, and serologies are associated with a whole plethora of antibodies. Titers usually rise 10 to 14 days post-strep pharyngitis and peak at around 3 to 4 weeks. And there's really no relationship with the development of nephritis or severity and the height of these titers. Question 7. A 52-year-old African-American female presents to the emergency room with unstable angina. She's noted to have a past medical history of mild chronic renal insufficiency, a creatinine of 1.8. She's transferred to the coronary care unit and therapy for unstable angina is initiated. A cardiac cath is planned for the next day. risk factors that would predispose this woman to contrast nephropathy include all of the following except A, diabetes mellitus, B, pre-existing renal insufficiency, C, the volume of IV contrast utilized in the procedure, D, presence of extracellular volume contraction, and E, a history of coronary artery disease. I'll pause for a second for you to answer this question. So the correct answer is E, a history of coronary artery disease. And of course, you know that in the most important risk factors are diabetes and pre-existing renal insufficiency. The volume of contrast is also viewed as a risk factor. Presence of extracellular volume contraction, also history of heart failure is also considered a risk factor. These are the main risk factors, but CAD is not a risk factor. Question 8. The same patient, her cardiologist asks you for an estimate of her risk of developing contrast nephrotoxicity. Which one of the following would be the closest estimate? A, 60%, B, less than 5%, C, 20%, D, greater than 80%, and E, greater than 95%. I'll pause for a second. The correct answer is C, 20%. So let's review with over these two questions, contrast nephropathy. So acute kidney injury or acute renal failure and oliguria usually occur in contrast nephropathy within 24 to 48 hours. That's the tempo of this disease, and the peaking occurs at 3 to 5 days following the initial injection of contrast. Usually these patients are characterized by low fraction excretion of sodium because the kidney is very sodium avid because contrast causes vasoconstriction. The sediment classically has granular casts, but can be associated with benign features. So you may get nothing in the sediment. And that's because those casts are stuck in the tubules and are not being excreted. Resolution usually occurs within about a week in most patients, but in some, these patients go on to renal failure requiring dialysis. And in a very small fraction, that dialysis is for an indefinite period. Risk factors that we discussed include chronic kidney disease, diabetic kidney disease, high doses, multiple myeloma, volume contraction, in fact, even heart failure. Prevention, the only thing that really works is hydration. And you can, the recommendation is 75 cc's, half normal saline. Some people argue that a better way to express that is 1 cc of half normal saline or normal saline per kilogram per hour. And usually you give that for at least a total of 500 cc's to a liter, depending on what the patient's condition is. In patients who have low ejection fraction or are already volume expanded, you'd want to be very cautious about treating them aggressively with fluid. And generally, it would be worthwhile using non-ionic contrast agents, particularly for high-risk patients. About 12% of hospital-acquired acute kidney injury patients develop this contrast nephropathy. The mortality is actually quite high, but it doesn't seem to be mortality associated contrast, but contrast is really traveling with whatever comorbidities the patient has and speaks to the increased mortality. About 0.7 patients who undergo diagnostic cath develop contrast nephropathy, and about 10% of patients who have a creatinine greater than 1.2 milligram per deciliter. And in our patient, with that level of serum creatinine, about 1.5, 1.8, the risk is around 20%. And it's higher among patients who are diabetic. And this shows you this risk. So you can see the risk goes up as the degree of renal dysfunction goes up. The risk factors we've already spoken of, pre-existing renal insufficiency, diabetes, heart failure, multiple myelomas on the list, volume depletion, and the dose of contrast agent. And the prophylaxis for contrast-induced nephropathy, the latest evidence is only volume repletion works. And acetylcysteine is not effective. Sodium bicarbonate is not effective. And this slide just summarizes very visually the latest data. This is a paper from Weisbord, published in the New England Journal in 2017, of 4,993 patients who were going for angiography, and they compared patients who had chronic kidney disease and were either diabetic or non-diabetic, and they enrolled patients who had moderate to severe renal insufficiency, and in this 2x2 factorial design, they either treated them with normal saline, bicarbonate, N-acetylcysteine, or placebo, and basically were able to demonstrate that neither bicarbonate nor N-acetylcysteine worked. Normal saline was the only effective agent for treatment of these patients. I'm going to stop there. Thank you very much for your attention.